Good morning, everyone. Welcome to our session on Vision Revive Recent Advances in Dry Eye Management. Dry eye is a condition which we encounter daily in our practice. We are honored to have a very distinguished panel of speakers in today's session. We have two keynote addresses in the session. Our first keynote address is by Dr. M. Vanati. Madam needs no introduction. She is professor in ophthalmology, specializing in cornea, ocular surface, cataract, and refractive surgery at RP Center, AIIMS, New Delhi. She is a distinguished academician, surgeon, and mentor, well known nationally and internationally. We also have a keynote address by Dr. P. Elankumaran, Medical Director of Navashakti Netralaya, Bangalore. Sir completed MD and later fellowship in cornea and refractive surgery from AIIMS, New Delhi. He earned his MD from AIIMS in 2001 and his MBBS from Bangalore Medical College in 1997. Sir is a prolific cornea surgeon and a regular faculty member at major national and international conferences. Our distinguished panel also includes Dr. Jairam Via, Senior Consultant in Cornea Refractive Surgery at Precise Specialty Eye Care, Dr. Bini S.T., Assistant Professor at Regional Institute of Ophthalmology, Thiruvananthapuram, Dr. Nimmi Raj, Consultant in Cornea, Cataract and Refractive Services at Precise Specialty Eye Care. I hope all of you will benefit immensely from this session. Thank you.
So we will start the session with an introduction with the dry eye challenge and overview by Dr. Ashwati V. Unnithan. She is a consultant ophthalmologist and dedicated consultant at Precise Specialty Eye Care. Over to Dr. Ashwati.
Good morning, everyone. My topic for today's discussion is dry eye challenge and overview. Coming to the definition of dry eye, after the DUCE 3 report, now the definition of dry eye, it is a multifactorial symptomatic disease characterized by loss of homeostasis of the tear film and or ocular surface. The key pathophysiology of dry eye is tear film instability, hyperosmolarity, ocular surface inflammation and ocular surface inflammation and damage and neurosensory abnormalities. Now, there is an increase in screen usage among all populations and reduced outdoor activities, especially post-pandemic, and we are seeing increase in number of dry eye cases. Now, let us see what the numbers are saying over the years. An early study done in the early 90s called the Beaver Dam Eye Study showed a prevalence of 14.4% in dry eye. This graph shows increasing prevalence with age of dry eye symptoms. Now, this graph is showing increase in prevalence with age, and also in women, dry eye tends to be more. Then another study came, which is called the Beaver Dam Offspring Study. And here the prevalence of dry eye was found to be 14.5%. And here also women were having more dry eye, incidence of dry eye. Also statistically significant association for dry eye was found with female sex, current contact lens usage, allergies, arthritis, thyroid disease, antihistamine and steroid usage. This graph is showing increase in prevalence of dry eye with age, and also women is progressively showing increase in symptoms of dry eye with age. Then another study done by Papas et al. Showed global prevalence of dry eye at 11.59%. Then a study published in 2023, it was a hospital-based study. The dry eye disease, the prevalence was found to be 29.5%. And here it was predominantly evaporative type of dry eye. Then this study done by Tithya et al. Here the prevalence of dry eye disease was found to be 32% and severe dry eye was found to be 28.9% among them. And here there was in the 21 to 40 age group, then male sex, unlike in other studies, here the male sex, they were having more incidence of dry eye. Then urban population, desk job with computer usage were found to have increased incidence of dry eye. Then we are hearing patients with screen exposure of more than 4 hours or more were found to have severe dry eye. Also, cigarette smoking and contact lens usage had increased prevalence of developing severe dry eye. The most number of patients in the 21 to 40 age group were having dry eye, and severe dry eye was 29%. Then statistically significant association was also found for severe dry eye with patients having desk job and computer usage, smoking, and contact lens use. Now we are talking about adults. Now what about children? In children also similarly, increased exposure of screen time, especially post-pandemic is happening, and increase in moderate to severe dry eye was found in children with increased exposure to screen time when compared to children with mild dry eye disease. And exposure time of 3 to 3.5 hours per day had significantly increased risk of dry eye. Coming to the conclusion, there is a steady increase in the number and severity of dry eye cases over the years. We need more multicentric studies in future to really assess the magnitude and burden of dry eye disease. Thank you.
Thank you, Dr. Ashwati, for giving the overview of the problem. Now I invite Dr. Nimmi Raj for the talk on precision diagnosis, advanced tool for ocular surface disease.
A very good morning to one and all. Now coming on to precision diagnosing dry eye precisely, what is the need? Are we diagnosing it correctly or just randomly telling the patient you are having dry eye, you take this lubricant, go home, you will be all right. So what is the need for a standard approach to diagnose dry eye? In order to have a uniformity among practitioners, for the patient to carry a valid report suggesting that he or she has a documented dry eye, and also to reassure the patient that the symptom that he or she is having is actually due to some underlying disease. There is this and this abnormality in your parameters, that is why you are having these symptoms, and we have treatment options for this. Clearly explaining to the patient that your symptoms are actual and we have a particular disease named this and the underlying factor is this. For that, there is a need for precisely diagnosing the disease. And also, secondarily, any disease needs to be precisely diagnosed to actually come to the conclusion of how much is the prevalence, how much is the incidence rising, what all care needs to be taken from the government side, what all research is needed further. So for all these purposes, precisely diagnosing dry eye is very important. Now, the diagnostic algorithm for dry eye was given by Deuce Stew in 2017. And in that, a systematic approach to how to approach a dry eye patient was given. First of all, a questionnaire has to be taken and then diagnostic tests were told, then classified into evaporative or aqueous deficiency and then manage accordingly. Now, recently, the Deuce 3 diagnostic methodology was proposed and they were analyzing, is there anything to be changed in the previous methodology? Are we going in the right direction in the previous, what all were told in the previous methodology? And also we needed to redefine, if at all needed, the previous definition of dry eye. So they found that there was no need to mainly change the dry eye definition. It was already told as multifactorial disease, and also the pathology was in loss of homeostasis of the ocular environment. And also specifically they have added the term that there is loss of homeostasis of the tear film as well as the ocular surface. That is the only change that has been made in the definition. And another major approach they have brought about is a new etiological driver-based approach. So what is the etiology for dry eye? They are subclassified it now not only into aqueous and evaporative. Whatever is the etiology, you take care of that etiology, manage that etiology so that the patient improves. And also they have given guidelines on possible future research or whatever is needed. So the diagnostic criteria is that in a symptomatic patient, that is, if the screening questionnaire is showing that the patient is actually having symptoms, the cutoff given is more than 4 points if the patient is getting on the OSDI 6 questionnaire. Previously, they had asked to use 2 questionnaires like OSDI 12 and DEQ5. Now they are telling just minimize the number of questions and lower the burden on the patient so that patient can also give you a value good response. So the OSDI 6 questionnaire is proposed and the cutoff score is 4. There is no such thing as mild, moderate, severe according to the questionnaire now. Previously there was with the OSDI 12 questionnaire. And the tear filling markers, they want one of either of these 3 to be positive to be diagnosed as a dry eye disease. So symptoms should be there. One of the 3 tests, that is tear filling markers, non-invasive tear breakup time of less than 10 seconds. In those places where there is availability to assess the tear breakup time non-invasively, that is the test that has been proposed. The value is less than 10 seconds. Then osmolarity, whenever you are able to assess the osmolarity, the machines need to be there. The values given are uniocularly or difference between the 2 eyes. Then the other diagnostic criteria is ocular sulfur staining. You have to stain cornea. Not only the corneal staining has to be checked, conjunctival and lid margin staining is equally important. Moreover, the cornea will show staining later on only. The lid margin and conjunctiva may be showing staining characters earlier. But the stain that is being used is Lissamine or Rose Bengal. The availability of stain also matters. So this is the questionnaire. I think we all can read it up later. The main thing is you have to analyze these things and give a value according to a 1 month experience. Previous 1 month, are you having these symptoms? Earlier on, the OSDA had it previous 1 week. Now they are assessing over a month. Tear breakup time is interval between a blink and the first appearance of discontinuity. It is a Placido disc-based technology is being used. The test, when it is done objectively, there is a universal mapping of the ocular surface. So we will know which all areas is actually having an instability in tear film. Temperature, humidity, air circulation will definitely affect the test values. There are so many machines available nowadays. IDRA, Tear Check Plus, Keratograph 5M are few of the options. Then when you don't have access, the algorithm from DUCE 2 also give you the option of fluorescent breakup time, but the value is less than 5 seconds. But instilling fluorescent itself will cause damage to the tear film stability, and that is the limitation. And it may not be an actual reflection also of the, and highly subjective. My tear breakup time may not be the tear breakup time for another practitioner. And osmolarity testing, most important is interocular difference. And many studies have shown that if there is an increase in osmolarity, those patients when undergoing a cataract surgery or refractive surgery might have more symptoms after the procedure. The limitations are osmolarity testing is not available everywhere. Location, according to from where you are taking the value, it might change. It's not a repeatable procedure according to the current instruments available. Staining is the strongest sign and which all of us can obviously do in our clinics. It indicates loss of surface homeostasis. Also, cornea with conjunctiva and lid staining is important. There are many grading systems available, whichever we can use. We can use the algorithm given by DUCE have used the Sika staining score for cornea and core grade for lid. It's an image showing corneal staining, conjunctival staining and lid margin staining. There are studies which show that staining is the main indicator of dry eye disease, omitting the other two like non-invasive tear breakup time, or even if you don't do osmolarity, the sensitivity or prevalent sensitivity doesn't decrease much. And DUCE 3 tells you that in a patient who has symptoms and signs, and in a patient who has symptom but no sign, in a patient who doesn't have symptom but sign, what all is to be taken or looked into. So if the patient is symptomatic, but when you examine there is no sign, in those patients will be having symptoms and no signs, then it can be neuropathic. There is an increased sensitivity to pain in that patient. or it is a transient discomfort. For the past 1 week, patient has been using screen too much or sleep is disturbed. So there is no sign as such, but the patient is symptomatic. But if the patient doesn't have symptom and when you examine, you are seeing signs, that means that patient is going to become symptomatic if at all you do a surgery or anything, or the patient might be diabetic having lesser sensation in the cornea, or neuropathic causes may be there underlying. If both symptoms and signs are present, you diagnose it as dry eye disease, but you have to have an etiology driven approach in which you have to assess where the tear film deficiency is in the lipid, aqueous, mucin layer, or is the blink of the patient, blinking rate is abnormal, or there is any pathology in the lid margin, any neural dysfunction, or any neural dysfunction or inflammation is going on. So there is no much time to go into everything. Now I'll come to the tools that are available, recent tools. There are many machines available. The most advanced or the most popular ones are the ocular keratograph, LipiView, IDRA, ocular surface analyzer. So IDRA is the name of the instrument. It is not an acronym. It will give you lipid layer thickness, tear meniscus height, NIBUT, and also infrared meibography. So you can eventually get all details from a single report itself and diagnose the patient as having lipid layer deficiency or aqueous layer deficiency, or is the blink of the patient abnormal, or meibomian gland as such is less in that patient. LipiView will give you an idea about the lipid layer deficiency, how much is the quality, quantity, what is the blinking rate, complete blink, partial blink. Also, the machine gives you a C factor in which it gives that the patient whether the test was reliable or not. There is another machine that is ocular surface analyzer. It integrates the question. Everything is assessed according to the methodology. DEQ questionnaire is integrated, and tear meniscus height, LLT, NIBUT, meibography, everything is assessed together. Another machine is ocular keratograph. It is an advanced topographer that will also give you almost all these values, TMH, meibography, hyperemia score, everything. Other few machines are also available. So whatever is that, if you don't have any access to the machine, still you can effectively diagnose dry eye disease by taking a proper, asking the proper questions, getting symptoms if the patient is actually having symptoms, and always lubricants can be started. There is a need for etiology driven approach. That is the best that is being proposed now. There is the need for a standardized, reproducible, repeatable dry eye protocol which needs to be given in the future. Thank you.
Thank you, Dr. Nimmi, for that very detailed presentation, especially in the setting of new dues out now. Now I welcome Dr. BDST to talk on innovative therapies transforming dry eye treatment.
The next topic is innovative therapies transforming dry eye treatment. The current treatment with the artificial tear for dry eye patients, which provide only the temporary symptomatic relief and does not address the root causes and pathologies like inflammation. Ideally, the aim of dry eye treatment should be not to progress the disease in a stage causing ocular surface damage because it's a late manifestation. So the current treatment is more focusing to treat according to the pathology than only the signs and the symptoms. Now we have some drugs acting at different levels and sites of pathological cycles of dry eye. Most of them are under experimental stage, some are released and FDA approved. Another important point to remember is both aqueous deficiency dry eye and evaporative dry eye may coexist in a single patient. These are not completely separate conditions. According to the current recommendation, we can treat dry eye patients with the artificial tear. And for meibomian gland dysfunction, we can give topical antibiotics and systemic antibiotics according to the severity of the disease. And for both, we can give a short course of topical steroids like lotepronol if it is associated with inflammation. Cyclosporin is another commonly available anti-inflammatory molecule we are commonly using for the dry eye. But now we have some modifications in the molecules like nano emulsion formulation combined with the perfluorobutyl pentane and micellar nanoparticulate formulations. All these can decrease ocular side effects, increase tolerance to become faster onset of action and increase bioavailability. Lifitegrast is also available here. It's an anti-inflammatory molecule which inhibits T cell adhesion and reduce inflammation. This also will take up to 2 weeks to 3 months to relieve the symptoms like cyclosporin. That means it will take time to act. Tacrolimus can be used, which is available as ointment here, which can be used instead of cyclosporin if the patient is not tolerating with the cyclosporin molecule or poor response with the cyclosporin. Coming to newer targeted therapy, the upcoming drugs, some treat signs and symptoms or some increase the production of tear or it can act as anti-inflammatory or repair damaged ocular surface. Coming to the some molecules, one is riproxalap, which is a reactive aldehyde species inhibitor. The importance is the presence of reactive aldehyde species on the ocular surface indicate oxidative stress. It's there in the dry eye. Another molecule is licaminlimab, which is an anti-TNF alpha eye drop, which acts as anti-inflammatory. It can be used in dry eye disease and also in uveitis. This perfluorohexyl octane, which is a drug for symptomatic relief, it's already FDA approved. It's specifically for evaporative form of dry eye. It's a water-free, preservative-free, and amphiphilic molecule which forms a monolayer which stabilizes the tear film when it is applied over the ocular surface. So it reduces the evaporation of the tear and it can be used in cases of evaporative form of dry eye. The next concept is neurostimulation. The drug is varenicline, which should be administered as a nasal spray. When it is administered inside the nose, it stimulates trigeminal nerve and stimulates lacrimose secretion and increase the production of tear, mebum, and mucin. The topical secretagogues like decofosol tetrasodium, ribamipide, and oral secretagogues like pilocarpine increase the secretion of this tear in cases of severe form of dry eye. Another concept is this activation of thermoreceptors. That means the drug name is accoltrimone. When it is applied over the ocular surface, it activates cold sensing thermoreceptors and generates cooling sensation, which trigger the production of basal tears and decrease the symptoms of a patient. So it is developing as ophthalmic drops, and cryosim act in a similar way, which should be applied over the lids. Visocolmitide, which is very helpful for regeneration of the ocular surface. It is a collagen mimetic peptide which repairs selectively diseased or damaged collagen and restore the structure and function of this ocular surface if it is damaged due to the dry eye. Next is topical selenium sulfide, which acts as keratolytic and keratostatic agent and slow down the progression or rate of keratinocyte proliferation, which is very helpful in MGD, which can act against demodics and also bacteria. It is hypothesized that the one cause of MGD is duct orifice keratinization. So this drug can reduce the incidence of this duct keratinization. It is developing as ointment. It should be used twice weekly to improve meibomian gland function. Another drug is lotilaner. Actually, this demodics organism causes blepharitis, which can be treated with tea tree oil. Lotilaner is a new drug, which is a lipophilic agent, acts specifically against mites like demodics. It should be used twice daily for 6 weeks. Rinsada is an irrigating device. It is using to irrigate on the ocular surface, which decrease inflammatory mediators and decrease the symptoms of a patient temporarily. There are many molecules are coming up, like thymosin beta for neurotrophic keratitis, senigermin, and visometine, which is a topical synthetic mitochondria targeted antioxidant. Carbonized nanogels, lacretin, lacripep, which stimulate the basal production of tear. Dietary and lifestyle modifications are very important to prevent the development of dry eye and in the treatment of dry eye. Adequate sleep and hydration is very important. The food factors like lutein, zeaxanthin, and vitamin D are known to increase tear volume and increase the stability of the tear. High saturated fatty acids known to produce inflammation and it should be reduced. Food rich in omega-3 fatty acids having some anti-inflammatory property and should be increased in the diet. So for a dry eye patient, low carb, low fat and high fiber diet is recommended. Apart from the already established treatments like thermal pulsation, intense pulse light and low level light therapy, there is another treatment method called quantum molecular resonance electrotherapy, which produce and deliver electrical fields with high frequencies and low intensity, which appears to be in resonance with the molecular bonds in the biological tissue, which stimulate metabolism and produce regeneration. So it can decrease inflammation, stimulate meibomian glands, and enhance surface healing. Blood products are also very important in case of dry eye associated with the ocular surface damage. Commonly used in ones are autologous serum and platelet plasma. These are rich in growth factors, which is very helpful to regenerate the epithelium. So it's very helpful in epithelial defect associated with the dry eye and also in neurotropic properties associated with the dry eye. So the shift of management is the newer upcoming drugs going to change the treatment pattern. The clinical focus went beyond merely lubricating the eye to address the pathology of the patient. So when a patient comes, understand the pathology, find out the dominating mechanisms and causes in a patient. According to the pathology, give a targeted therapy or a personalized treatment. Multiple therapeutic targets should be addressed simultaneously for a patient. Drugs with specific molecular targets and enhanced delivery system should be prescribed, aiming for improved efficacy, faster onset, and better tolerability. So the shift is from symptomatic relief to etiology-driven management. Thank you.
Thank you, Bini Madam, for that extensive talk on medical management of dry eye. Now I invite Dr. Jairam Via to give a talk on surgical synergy integrating dry eye management in severe cases.
A very good morning to all. Today I will be talking regarding surgical management of severe dry eye. So in the DUCE 3, there is some change in the focus as earlier speakers told. The traditional definition of severe dry eye in the symptoms scores were more than OSDI more than 33 and ocular surface staining more than 3. But the severity in the DUCE 2-3 update is the level of homeostatic threat and not just symptoms. And a patient becomes refractory when the underlying anatomical and physiological defect is not correctable with medical therapy alone, and surgical intervention becomes necessary to restore the ocular surface stability. So these are the 4 points which are highlighted in the clinical profiles as refractory or severe DED, that is absolute aqueous deficiency seen in that's a total lacrimal gland failure in Sjogren's graft versus host disease, Stevens-Johnson syndrome, etc. And neurotropic keratopathy in which persistent epithelial breakdown despite adequate lubrication, and anatomical incongruence as in lack of thalamus, entropy on conjunctival etc., where topical therapies are ineffective and persistent epithelial defects not healed after 2 weeks of intensive therapy, which suggests limbal stem cell dysfunction and altered cytokine environment. So indications of surgical intervention are medical therapy failure, severe aqueous deficiency, exposure on neurotropic keratopathy, meibomian gland dysfunction, anatomical abnormalities, and surface reconstruction needs. So according to the DUCE 3 framework, if the as it is a new concept of the driver is introduced, in which if the Schirmer test is less than 2 millimeter and there is severe aqueous deficiency, salivary gland transplantation, and if in neurotropic keratopathy, if it's severe, then corneal neurotization. And if there is eyelid anomaly, then tarsorrhaphy or gold white implantation or canthoplasty. And in recurrent plug extrusion or stenosis, then thermal punctal cautery. And non-healing epithelial defects more than 2 weeks, amniotic membrane transplantation. And if there is surface disorders like pterygium or conjunctivocalasis, then autograft or conjunctivoplasty. And in obstructive MGD, refractive to compression and medical therapy, intermittent thermal pulsation and probing. So punctal occlusion is one of the common procedures we do when the shimmer value is less. There are two types, collagen plugs and silicone plugs. Collagen plugs are temporary, which dissolve over 4 to 7 days, and silicone plugs, which is semi-permanent. It is minimally invasive, quick office procedure, but you should make sure that the patient is having severe aqueous tear deficiency, otherwise it can cause epiphora. The complications are spontaneous plug loss, canaliculators, or granuloma formation. This is very simple procedure. This is a silicone plug which can be implanted in your OP with the skillet. You can just implant it and keep it there. It improves the tear film retention in your eye drops in the eye, improving the tear film symptoms and ocular surface as such. Then permanent punctal occlusion is indicated in severe aqueous deficiency, unresponsive to plugs are intolerant. You can use either thermal cautery or electrocautery. Its long-term benefits are sustained tear retention, but there is a potential risk of epiphora, and it's irreversible. And another problem is when you do cautery, there is a high chance of recanalization, around 20 to 25%. Mainly, there are some studies which show that it's due to the use of steroids in the initial phase. So steroids should be avoided for 7 to 10 days. Only use lubricants and NSAIDs, which will lead to better fibroblastic proliferation and better occlusion. Meibomian gland procedures targeting the lipid layer of the tear film. Thermal pulsation, that is LipiFlow and similar devices applied to control heat and compression to the inner eyelid, liquefying and expressing the mebum. And intense pulse light therapy to reduce periocular inflammation and telangiectasia, which will improve mebum quality and modulate inflammatory mediators. And meibomian gland probing can also be done to break the periductal fibrosis and open cystinotic orifices in focal obstructive disease. So conjunctival procedures like conjunctival recession in conjunctivocalasis can give symptomatic relief to a certain subset of patients. Amniotic membrane transplantation is one of the common procedures which will improve the epithelialization, reduces inflammation and inhibits scarring. It's particularly useful in persistent epithelial defects, unresponsive to medical therapy, and severe ocular surface disease and inflammation, chemical or thermal injury, and unresponsive recurrent corneal erosions. So these are available in different types. This is a dehydrated amniotic membrane graft called Omnigen, in which you can you can store it for a much longer time, or dehydrated freeze dried also is available. So you can apply it over the paper snip till defect and either suture it or with use glue. Then eyelid and lacrimal procedures, a lateral tarsography, which will give partial fusion of lateral eyelids, causing palpebral fissure width decrease, and effective for lagophthalmos and exposure keratopathy. And eyelid malposition correction of ectropion, entropion, etc., optimizing tear distribution and eliminating corneal irritation. And eyelid weight implantation for basically facial nerve palsy, restoring protective blink mechanism. So advanced ocular surface reconstruction in who are non-responsive to other measures, either by limbal stem cell transplantation, it can be autologous or allogeneic stem cell grafts, restore the epithelial regenerative capacity, and keratoprosthesis, in which all the other treatments fail. To summarize, the key takeaways are surgical interventions of dry eye disease are reserved for refractory or severe cases after exhausting all medical management options. A systematic etiology-based approach optimizes outcomes. And therapeutic targets are tear retention through punctal occlusion strategies, gland function through meibomian gland stimulation procedures, improve eyelid mechanics through malposition repair and protective measures, and surface reconstruction in late or unresponsive cases. The treatment must be individualized based on disease etiology, severity, and patient-specific factors, and ultimate goal is restoration of ocular surface health and meaningful improvement of visual function and quality of life. Thank you.
Thank you, sir. You dive deep into the surgical management of dry eye. Now I invite Vanidhi Madam to deliver the keynote address.
At the outset, I wish to thank the organizers, and specifically Ashwini and Jairam, for having me here in this fantastic course. And many congratulations to all the ophthalmologists of Kerala on your 52nd annual conference. I think the previous speakers very elegantly covered almost all aspects of management and all how the TFOS Dues 3 has changed from the TFOS Due 2 deliberations or elaborations of how you will have to approach dry eye. So now I'm going to talk to you on what's probably new or what can we actually adopt in the way we are managing dry eye disease so that it brings about a better refractive outcome or a better clinical outcome to our patients. I do not have any financial interest in the mention of any of the products during the course of this talk. So when you look at dry eye treatments, what is the alma mater of devices we have? We look at local agents which can probably help in increased tear production. And what we have new in that field or in that aspect is nasal sprays here. But it's still yet to be available in India. You could probably get them from abroad online, but these are yet not available in India for management. So that's something which is lacking, but that is to start with what's new and available in nasal spray therapies. When you move to punctal plugs and how you can adopt punctal plugs in your management, I think Jairam has very nicely elaborated those aspects here. But a few key points you will need to understand is when you will have to use the punctal plug, what type of punctal plug will you need to use. You want to use a temporary or the permanent ones here, and what investigations you need to do on your patients before you would consider punctal plugs. So these aspects are critical when you are managing dry eye disease patients. It's not a one size fits all kind of a management when you are managing dry eye treatment. That is something you need to understand. And in those patients where you are having an aqueous deficiency dry eye disease, where you want to decrease the evaporative loss of the already existing lesser pool of tears, is where you're going to apply your punctal plugs here. And if there is an inflammation component already present on the ocular surface, then you will probably need to treat the inflammatory component before you're going to plug the outlets here. Because if you're going to plug the outlets on an inflamed ocular surface, that's going to increase the surface inflammation and the discomfort quotient and the epithelial damage here. So this is critical in understanding what is the timing and what is the right subset of patients where you will be successful when you're using punctal plugs here. If you're dizzy and you do not know whether it's really going to work, that's when you're probably going to use the approach of temporary punctal plugs. And then when you find it is suitable for that particular patient, you will probably move on to use permanent punctal plugs for these patients. So these are some sort of, management guidelines or some sort of understanding of the basic pathology of the patient you're treating, which is going to help you in the success of the outcome when you're managing dry eye disease patients here. And now moving on to the next, we have the anti-inflammatory medications. I think there's a lot of new entrants in this particular field here. And what we need to understand is which anti-inflammatory agent is probably going to help you and when you need to apply them for the success and management of your patients. And of course, the specialized devices which we have in dry eye disease management. So Tariva is from Oyster Point is a varenicline, which is an FDA approved one, but it's still not available in India. You have the variety of punctal plugs which already elaborated to you. We'll now move on to anti-inflammatory agents which you need to have. I think a lot of which has already been said where you have lifitegrast, which is the new entrant. We do have several commercial formulations which have now come into the Indian market here. And this is an LFA1 antagonist, so lymphocyte function associated antagonist here, where it blocks the adhesion to the ICAM1, which all induce inflammation and inflammatory mediators release here. And most of the commercial available agents, the pharmaceutical companies claim that it gets into action as early as 2 weeks vis-a-vis compared to the earlier anti-inflammatory molecule, which was cyclosporin, which has been approved. So lifitegrast is the second anti-inflammatory molecule, which is FDA approved for treating ocular surface inflammation in cases of dry eye disease here. But I think I personally do not use a lot of lifitegrast, and my discussions with those who are using lifitegrast is not that it is very proactive. It's probably similar to how cyclosporin is functioning here. So we still do not have a molecule which is going to be giving you an effective, immediate anti-inflammatory action, just as you would need, just as you get with steroids. So I think steroids still remain the first line of management when you want to control surface inflammation and the potency of the surface steroids you want to use, whether you want to use a high potency surface steroid, a medium potency surface steroid, or a low potency surface steroid will be dictated by the severity of the ocular surface inflammation which you are looking at in your patients here. So lifitegrast, the mechanism of action, I think already was well described by Benny here. So these are more of textbook, and if you have postgraduations and fellows here, I would urge you to go back and look at the mechanism of actions here. The dosages available is 5%, which is 50 milligram per ml is what is available. It's claimed to work at 2 weeks, but I think you will need a longer installation before these drugs are going to come into action here. So what we have moved on from anti-inflammatory is to the targeted approach to management of dry eye disease, or how you use medications for targeted approach. I think the biological tear replacements in terms of using autologous serum in use of platelet-rich plasma. So these are all medications which have been available, but the only downside to it is you do not have them commercially available, and you will have to resort to an in-house pharmacy if you have one, or you have to resort to centers who can make this from the patient's own blood here. So that's the downside, but they are rich in a variety MIG or multiple growth factors, which helps in healing of the ocular surface where there is epithelial damage here. So that was something which has existed for over 2 decades. But how have we moved out, or how have we climbed further in the targeted approach to dry eye therapy is where we are looking to particular agents here which will act on those molecular pathologies which are causing the inflammations here. So what we have is a low dose heparin which acts on the nets of the ocular surface. So what's our nets here? These are extracellular nuclear traps here. So when ocular surface inflammation occurs, there are a lot of extracellular release of DNA material here, which is probably responsible for the refractory ocular surface inflammation, which does not respond to your steroid therapy in certain subset of dry eye disease patients. So identifying these nets and identifying particular medications which will act against these nets is also going to increase your outcome, especially in those group of refractory patients where you're going to need these medications here. So this is a fantastic picture, and I'm talking to you more about it because my topic is about visionary research and what we have found is really going to help and what is probably accessible to in our clinical practices here. So this is particularly a new discovery where we are looking at the presence of ACPs or anti-citrullinated protein antibodies which are present in the tears, and this led to the concept of use of topical immunoglobulins, IVIG drops. We can use the intravenous immunoglobulins, formulate them to ocular surface immunoglobulin therapies, and these will particularly act on the surface nets to decrease the surface inflammation and bring about better response to the treatment which you are having in these patients. Ocular GVHD, severe SJS patients, severe Sjogren syndrome patients are those subsets of dry eye disease patients which do not respond to the conventional topical managements, and these are the subset of patients where you will need to resort to adoption of such targeted therapies, and they do work well. For those of you who are interested, I would refer to our latest recent publication here, which will give you a particular insight on the success and how you would go about of managing patients using ocular surface immunoglobulin IgG therapies for these subset of severe dry eye disease patients. Yeah. Again, what is new and probably been, this is a revolutionary paper which came out about 4 years ago here, round about the period of COVID here, when NETs was identified as the reason for refractory ocular surface inflammation. And then using a particular medication such as the topical DNase 0.02% here. So this is recombinant DNase. This has been available and has been used for patients with cystic fibrosis, particularly in pediatric pulmonary fibrosis patients here. Availability is a particular difficulty here, but recombinant DNase works fantastically well when you are using it on patients with severe refractory dry eye disease well. So we've just concluded our research on the use of adjunct therapy with topical recombinant DNase, and this really helps in resorting to the patient, resorting to an increased comfort levels and decreasing the clinical signs and symptoms of these patients. But again, understand that all these targeted therapies work optimally only once you have probably reduced the severity level of the surface inflammation using topical steroid therapies. You optimize the surfaces and then you resort to adjunct therapy with these targeted molecules, and they will help you in better outcomes of these patients. The devices, I think you have several devices starting from thermal devices, intense pulse light devices, QMR electromagnetic field devices, which all help you to give you a better to help you in the ocular surface problems here. But then here you remember, this is where patients have lid disease, chronic lid disease, which is probably contributing here. So it's not going to be applicable for all subset, but you will have to know what is the source and what is the diagnosis which is causing dry eye disease and where you need to apply these patients here. So Procera, again, these are devices or amniotic membranes which are commercially available, which can be applied onto the ocular surface. But what I do find effectively, which we can adopt to our practice, is how we use scleral contact lenses for patients. You need not really always use pros contact lenses, which are very expensive. You could effectively use with optimal fitting. So you need a really devoted team here of your your corneal physician and your optometrist to work in close tandem. The ocular surface needs to be optimized in terms of controlling the ocular surface inflammation, and then move on to adopt to the wearing of these scleral contact lenses, which can be both therapeutic and refractive for the patients here. This is one of my patients of Stephen Johnson's who presented very severe dry eye disease, refractory to the traditional treatments. And when we slowly optimized his surface and moved him on to scleral contact lens, he's now on scleral contact lens for almost 4 or 5 years here. He's a computer professional and it's very comfortable using his surfaces. And it's amazing to see how these eyes do turn on from being inflamed eyes to white eyes such as this. But then you do need a continued team effort and continued close follow-up for effective management of these patients here. So that's a few of our clinical pictures of those patients who are on scleral contact lens wear as therapeutic measures for contact lens for ocular surface disease here. I will stop here and thank you for your patient listening.
Thank you, madam, for that excellent talk on the future of dry eye therapy. So there is some time since Dr. Ilan is not here, so we will have a short discussion. So regarding the targeted therapy, those DNA drops and all, you will have to make for individual patient with their cellular signature.
Yes, we now completed 2 research projects where we used ocular surface immunoglobulin therapy. This can be made with intravenous IVIG immunoglobulin is available with multiple ones. The ones we used is from Entas. So Entas gave us their molecule Globicel, and this can be into an ocular surface immunoglobulin therapy. So you do need an in-house pharmacy which is able to make the required concentrations. For recombinant DNA polymerase, which is available for treatment of cystic fibrosis, so we procured this recombinant DNase here. It was initially available with India, but during the course of our thesis, it was not easily available. So I had to get it from USA when I went there. And much of this research on identifying NETs as the responsible molecular pathology for refractory dry eye disease is from Dr. Sandeep Jain and his group. He's from Delhi, but he's currently is a high-profile researcher working with Chicago, the University of Chicago there, and it was his discovery where they looked at NETs here. So you will have to again procure the medication. There is a difficulty. But this is promising in terms of giving good relief for patients such as severe SJS, severe Sjogren's, ocular graft versus host disease in patients who undergo hematological stem cell transplants. This is a particular subset of patients where your dry eye disease is really difficult to manage with conventional approach.
Madam, is your basic aim to reduce chemotaxis and stop the inflammatory process from taking place? Now, there are a few drugs, levetiracetam is one like that.
See, whatever we do, I don't think we can completely stop the amount of ocular surface inflammatory mediators. You could probably bring them to the lowest possible ebb. And that's what you're looking at. And that depends upon the severity which is affecting. It could be each patient would not have the same type. Some would have a mild severity. Probably you would be successful in bringing them to a nil level of chemotaxis. Yeah.
It's not possible if you reduce chemotaxis. But if you give steroids, that can delay healing also. So you cannot, that one drug probably reduce the chemotaxis, spare the steroid. You don't give steroids too much. And that's very
so
important.
The steroids is not something you need to give for a long period of time, but you'll have to change the potency of the steroids, and some of them might be steroid dependent on a...
It can reduce the ocular surface immunity.
On a one
so
stage.
Steroid should be avoided.
So that's why now there is a concept of bringing in systemic anti-inflammatory therapy targeted. So that's something which there's a lot of work going on in it. Its adoption to dry eye disease, if in terms of ocular GVHD, we do give JAK inhibitors. For those who are refractory, even with these approaches, we are now moving towards giving JAK inhibitors. So again, there is a lot of thought, but we reserve it to a very small school of patients, such as those who have undergone hematological malignancies, where you really need to give them a better quality of life. That's when we move it. But this concept is, yes, something, if we can really adopt that and we can successfully find an answer, then we have won in dry eye disease. One question to you, Jairam, is the amniotic which you used in your thing. Can you just elaborate on that? This video which you showed.
Yeah, that is a dehydrated amniotic membrane commercially available called Omnigen.
Okay.
So that is supposed to have more anti-inflammatory mediators in that than the freeze-dried one. But this can be, the advantage is that this can be stored for a long time, maybe more than 6 months.
And it disintegrates how fast after you put it on the ocular surface?
It will, it won't, it will stay for at least 1 week, at least.
Thank you.
And one more thing I just wanted to discuss is now for evaporative dry, mainly lipid-based therapies, drops are coming. So the Binny is not here. So she mentioned a few drops in which the lipid supplements and the tears are supplemented. So we have Cysteine Complete, which has phospholipids. Then myoglycol is there, castor oil is there, and one more per hexyl octa that molecule. So a large subset of patients are actually evaporative dry. They have good tear secretion, and there is no point in giving carboxymethylcellulose or our hyaluronic acid like that. So which lipid substitute would you recommend for evaporative drying?
I basically do not find one better than the other. I think we have several in the market here, and we have several. You have HPMCs here, you have CMC here, you have combinations of HPMC, CMC with PEG-PGs. Then you have the lipid containing, which the company so claim would probably give them better here. And you have sodium hyaluronate, and you have those with better demulcents added onto them, better electrolyte ones added onto them. But if you really, if I tried understanding from my patients who are there, who are chronic and coming to them, and you find that in some, as you mentioned, Cysteine Complete seems to be working. But in some, they say they are absolutely do not like, and they themselves move into a lubricant with a lower viscosity index. So I think at the end of the day, it is perhaps what suits the ocular surface of one particular patient, because we are really not looking at how much is the hyperosmolarity quotient, how much is the electrolyte quotient on these patients, how much is the epithelial cell deficiency quotient on these patients. And if for evaporative dry eye disease, I think the first thing would be a lifestyle modification, which is going to be imperative for this. Rather than you giving more, any typical or any different varieties of your tear lubricants here, unless you have a successful lifestyle modification, your success rate is not going to be working for those severely affected, aqueous or evaporative dry eye disease patients. And again, another component which I have seen is that it's no longer just aqueous deficient or no longer just, evaporative. Now we do find there is probably a mixture of these components, and the percentage of the mixture is probably different depending upon the pathology. Most of them, what you talk about, if it's a simple dry eye disease evaporative because of a computer vision syndrome which are there, or because they are, their blink rates have reduced as they are using their digital screen time is higher, then your treatment is particularly different. But then if you have an evaporative dry eye disease which is associated with a meibomian gland dysfunction, so you have a meibomian, then your treatment level. So, and in several you might find a combination of both, the quotients might be different. So I personally don't recommend one over the other. I, in fact, do find some of them without lipid content still work in these pathologies.
I gave a thought to that lipid content, right? And physiologically, lipid is secreted as the outermost layer. It is like giving insulin into the systemic circulation rather than the portal circulation. That is where it is required. So if you pour lipid into the eye, it will all mix up with the whole. So the rationale I still don't believe, but I write those eye drops, but actually it should be the outermost layer. It doesn't come like that. When you give the drops, it mixes. I don't know how it will help. The eye, the lid closes, secretes a layer of lipid, the lid retracts. That is required because that's the time you operate. It clears lid only. Here, so that's where it is wanted. But it doesn't work if you put drops.
Thank you everyone for the wonderful discussion and thank you for participating.